So the initial two large pivotal randomized controlled trials, the OPERA 1 and 2 studies, compared ocrelizumab to interferon beta 3 times a week. And this shows significant higher efficacy of ocrelizumab versus interferon beta as related to relapses, MRI activity, and preventing disease progression. However, the two studies included over 70% of relapsing-remitting patients that were naive to any DMT. So the data provided only the comparison to interferon therapy. The CHORDS study that we're discussing now was designed with the rationale to evaluate the effectiveness and safety of ocrelizumab in patients with relapsing-remitting multiple sclerosis who had a suboptimal response with prior disease-modifying therapies. So the inclusion criteria for the CHORDS study required to include the relapsing-remitting patients with a disease duration less than 12 years, and the suboptimal therapeutic disease control on one, maximum 3 other disease-modifying therapy. And the suboptimal disease control on a stable dose for at least 6 months was defined as one or more clinical reported relapse on this medication, presence of T1 GET-enhancing lesion, or presence of 2 or more new enhancing lesions. The primary endpoint of this study was defined as the proportion of patients during the 96-week study. They are free of protocol-defined clinical or MRI measures, and that's included presence, or meaning being free of relapses, protocol-defined relapses, no confirmed disability progression as assessed by the EDSS for 24-week, and no T1 GET-enhancing lesions, no new or T2 enlarging lesions. The study included also patient-reported outcomes, looking for treatment satisfaction as compared with the previous disease-modifying therapy. Ensure safety and tolerability were evaluated during this 96-week study. The results of the study showed that actually no relapses in this patient previously active. No relapses were seen in 90% of patients. No confirmed disability progression, also up to 90% of patients. No GET-enhancing lesion in 95%, and no new enlarging lesion in 60% of patients. Altogether, the primary no protocol-defined events were seen in 48% of patients. There were no malignancies. There was no death. Using the treatment satisfaction questionnaire, including the patient-reported outcomes suggesting increased satisfaction as related to efficacy, convenience, global satisfaction, as well as benefit as side effects compared with the previous DMT. So, as mentioned, this study complements the findings from the initial pivotal studies showing the benefit on relapsing-remitting patient as used as first-line therapy, but these are also for the patients with previous suboptimal response to other disease-modifying therapies. The majority of patients enrolled in these studies were around 30% from glatiramer acetate and dimethyl fumarate. There were also from Gilenya, 15% of them, 9% from teriflunomide, and the rest from interferon. So showing most of the disease-modifying therapy that patients did not respond can really respond better within the ocrelizumab. There is no really consideration of contraindication at this time. In general, what all the disease-modifying therapy is trying to determine is the benefit on much earlier intervention within the kind of first year from disease onset. There are also consideration of targeting more specific ethnic population with known more severe disease progression, ensure the extending data on the benefits previously seen in primary progressive MS patients.